I'm now in your office. You've diagnosed me. What's the conversation we now have? So I have this thing, CLL, I sort of understand it. What's the next step?
After diagnosis?
I'm in front of you in the exam room. Now what?
So we're at the point of one, do we treat or is it a watch and wait? Well, what is our treatment plan? And treatment plan can be observation, which seems a little odd when you're talking about a chronic lymphocytic leukemia.
Right.
They hear those words as very scary. But we have to remember a chronic lymphocytic leukemia is a chronic condition.
Right, chronic and oncology oftentimes you don't put those two things together, right?
Correct. But CLL is a disease state that can be watched sometimes, but you need to monitor closely.
Watchful waiting.
Yes, watchful waiting is one treatment option.
Okay.
But then sometimes you do need treatment. And then that's when we would decide on a treatment plan, whether it be oral or IV treatment options.
So oral is another word that I don't typically associate with oncology. So we've now have these oral oncolytics, and how has that changed? You know, so if I was sitting in your office 5 or 10 years ago versus now, I've got this, it's different. So tell me,
Yes.
How much different is it now?
It's very different.
Okay.
10, 15 years ago, we didn't even talk about oral oncolytics for CLL. We had very few oral oncolytic therapies for any cancer process.
And we're not talking about radiation.
No.
No, so that's off the table.
Radiation is off the table in
I'm
CLL.
talking about
Yes.
basically these infusions.
Yes, it would
and-
have been an IV if we needed treatment for CLL, we would have talked about IV therapies.
Okay, and now I've got this option of oral oncolytics, so as I'm sitting there looking at the options, I can take this with me to my summer home,
Yes.
I can go through therapy, and so from your practice perspective, it's changed how we interact and treat patients then,
Definitely
right?
changed our interaction with patients. It's changed patients' lifestyles also.
Okay.
So one, they either were coming in, say, every 3 weeks for therapy. You know, it could have been a treatment plan for, you know, coming in for, you know, several hours once every 3 weeks for 6 treatments, versus now they just take a pill every day for the rest of their life and come in for their follow-ups.
Oh, interesting. So there's another concept of
Yes.
it truly is a chronic
Yes.
disease state. So oncology with the concepts of type 1 diabetes actually mixed together. Look, this is going to be something we're going to be, until gene therapy comes around, we're going to be doing this for quite a long period of time because it's a chronic disease state.
Definitely something that we educate patients on, that this is a chronic
So it's doubly
condition.
important in this particular
Yes.
space as far as the oral oncolytics. I can live my life and have this
Yes.
chronic oncologic scenario. So is there, what's the algorithm look like? Is it first line, second line, like other conditions, or what, you know, as you're presenting these options, how do you present them? You know, first option, second option, third option, what does that look like?
Several years ago, we were even, say 2 years ago, we were still presenting the option of possibly an IV for 6 cycles versus an oral, especially depending on patients' finances. But now, with the data to support, the oral has taken first line.
And what type of data?
The clinical data to support the outcomes.
Okay. And are you seeing that at Mayo? You practice at Mayo Corollas,
Yes,
and in a large health system?
Yes, sure.
So you have a lot of data. What's been your experience in a very large practice?
So one important thing in, when we initially diagnose patients is really determining their comorbid states. So as Christina was saying, there are 2 groups of patients. So CLL is a disease of the elderly. So oftentimes these elderly patients are more frail. They're not able to tolerate extensive chemotherapy. So with the advent of oral oncolytics, this has given us extensive opportunities to be able to treat patients with therapies that are more tolerable, therapies that they can take on the outpatient setting, so they're not coming to have to come to clinic and whatnot. So, and primarily this has really been ibrutinib that's really changed the face of how we treat CLL. An important thing also to determine up front in CLL is their cytogenetics, is the karyotypes that these patients have. Are they, deletion 17p? Are they deletion 11q? Because a lot of these cytogenetic abnormalities are associated with, more aggressive disease that's more likely to progress, extensive lymphadenopathy, splenomegaly. So that also helps us determine which patients we may watch and kind of see how they do as they, do they become symptomatic versus the ones that we need to initiate rapid treatment on. I think historically, age was a big factor. Patients less than 65, we need to treat them. Patients older than 65, we can watch and wait. And also, again, the comorbidities were there, as well as the deletion status of 17p. That was the big driving prognostic factor.
So what I kind of hear you saying then is, we used to think in terms of age, risk, reward with older options, but now that we have newer options, this concept of there are 45-year-olds that present as 65-year-olds and there are 75-year-olds that present as 55-year-olds, we're looking very much more at the specific condition, the specific variant, and also the comorbidities. And really, so there's still somewhat of a practice and an art here to the actual, here's what our plan of care is, very individualized, it seems.
Absolutely, absolutely. So every patient is going to be different in how we treat them based on how they present.
And I think one other thing to consider, we all consider, is the differences between orals and IVs. When you have a patient that's going to be infused, they're in your chair and adherence is 100%. But with orals, adherence becomes an issue. So convenience and independence goes up, but the risks associated with non-adherence goes up also. And then, of course, we're talking about the medical benefit on the IV side and now the pharmacy benefit on the oral side. And Christina and Carlos mentioned the financial impacts of having an oral therapy and what does that look like to a patient. And all of that goes into the decision-making process with the provider and the patients.
And is it highly variable from an out-of-pocket perspective? Not generalized, but it could be any kind of circumstance with different types of payers and different types of diagnoses and circumstances and prior auth and so on and so forth?
Yes.
Absolutely. So there are definitely different models, whether patients are receiving infusion or oral oncolytics, and both are expensive because when you look at the infusion side, they're receiving, for example, anti-CD20 monoclonal antibodies, which are nowhere near cheap. And then on the oral chemo side, you have these targeted therapies, which are also expensive, but oftentimes, with that billing model and, the types of dispensing models, it all varies throughout.